Hello, everybody. Welcome to this session on fever of unknown origin in adults. Today, we will discuss what FUO is, how to evaluate such patients systematically, and the management principles that guide our practice. FUO continues to be a fascinating clinical challenge requiring careful reasoning, multidisciplinary input, and sometimes patience. I will walk you through definitions, categories, diagnostic strategies, and outcomes, ending with some practical key takeaways. So, when we talk about FUO, we mean a fever that persists beyond the expected duration of common illnesses without an identifiable cause. Unlike routine febrile illnesses that resolve on their own or declare their cause quickly, FUO lingers and remains a puzzle. Most patients with fever eventually develop distinguishing features like a rash, organ-specific symptoms, or abnormal laboratory findings that point us toward the diagnosis. FUO is different because, despite investigations, the cause is elusive. This is why a structured, methodical approach is critical in FUO. Jumping to conclusion or using random investigations can be misleading. Instead, clinicians must rely on a stepwise evaluation, history taking, and a broad yet rational differential diagnosis. The definition of FUO requires a documented fever above 38 degrees centigrade. Importantly, this needs to be confirmed on several occasions, not just one isolated reading to exclude spurious measurements. Traditionally, FUO requires at least 3 weeks of fever. This duration helps distinguish FUO from prolonged viral infections or transient unexplained fevers that self-resolve. The third criterion is crucial. Patients should have undergone a reasonable diagnostic evaluation by an experienced clinician, including basic laboratory investigations and imaging without yielding a diagnosis. This separates FUO from situations of incomplete workup. Over the decades, large clinical series have helped us understand FUO's spectrum. They provide insight into common causes, diagnostic yields, and trends across time. With the advent of better microbiological tests, molecular diagnostics, and imaging like PET, CT, the approach and definition of FUO continue to evolve. What was once considered unknown is now more often explained. Despite progress, FUO remains a diagnostic challenge. A significant proportion of patients still go undiagnosed after thorough evaluation, making FUO an important learning area in modern medicine. Now, categories of FUO. There are four categories. These are classic FUO, healthcare associated FUO, FUO in immunocompromised patients, and travel associated FUO. Now, classic FUO refers to patients in the community with no recent hospitalization, immunocompromise, or travel exposures, yet presenting with prolonged unexplained fever. Healthcare associated FEO, this category includes hospitalized patients or those recently exposed to healthcare where nosocomial infections, post-operative complications, or device-related infections may be responsible. FEO in immunocompromised patients. Immunocompromised patients face unique risks such as opportunistic infections or malignancies. And finally, travel-associated FEO reminds us to think of tropical diseases and endemic infections not usually seen in the local setting. Now, a little bit more about classic FEO. In classic FEO, the fever threshold is generally defined as greater than 38.3 degrees centigrade, persisting for at least 3 weeks. This criterion ensures that only prolonged unexplained fevers are captured, ruling out self-limited viral infections or temporary spikes that resolve quickly. It is important because clinicians often encounter prolonged fevers, but not all meet the threshold for FUO workup. The defining feature is that despite appropriate outpatient or inpatient workup, no diagnosis is found. This means patients have already undergone initial lab investigations and imaging investigations without success. It highlights the necessity of careful logical expansion of the diagnostic process rather than endless random tests. Not every prolonged fever needs to be labeled FUO. Clinical judgment is key. Sometimes patients fall short of the rigid definition but is still worked up due to concern for serious conditions. Conversely, others meet criteria but have an overlooked straightforward diagnosis. The clinician's insight makes all the difference. Now, healthcare associated FUO. Healthcare associated FUO occurs in patients who are hospitalized or have recently undergone surgery. In these individuals, the risk factors differ from the community cases. Causes may include catheter-related infections, ventilator-associated pneumonia, post-operative complications, or hidden abscesses. ICU versus non-ICU presentations require differentiation. Distinguishing between ICU and non-ICU hospitalized patients is important because ICU patients often have multiple invasive devices, making them more susceptible to nosocomial infections, while non-ICU patients may develop fevers from hospital-acquired pathogens, medications, or procedures. And also, you have to consider nosocomial infections. The priority in healthcare-associated FUO is to rule out nosocomial infections because they can progress rapidly. Blood cultures, catheter tube evaluations, and imaging studies should be tailored to identify hidden hospital-acquired infections that are often resistant to standard antibiotics. Now, FUO in immunocompromised patients. Immunocompromised patients form a distinct category of FUO. Neutropenic patients, transplant recipients, or individuals with advanced HIV have profoundly different risk profiles, with opportunistic infections that rarely affect immunocompetent people. These patients may harbor fungal infections, unusual bacterial organisms, or viral reactivations that don't appear in standard FUO categories. The absence of normal immune defenses changes how infections manifest, making them more difficult to detect and diagnose. The clinician must think beyond routine causes and use a tailored approach, often involving early imaging, fungal biomarkers, or bone marrow evaluation. Immunocompromised FUO often requires multidisciplinary management, including infectious disease and oncology specialists. Now, travel associated FUO, this is an increasingly common presentation in today's globalized world. A patient who recently visited another country may be incubating a tropical or region-specific infection that is unfamiliar to clinicians in their home country. Diseases like malaria, typhoid, schistosomiasis, or leishmaniasis should be considered in travelers returning with fever. These may present weeks or even months after travel, making careful documentation of travel history crucial for diagnosis. The key here is exposure history, where the patient stayed, what they ate or drank, where they swam in the rivers or had insect bites. All these are potential clues. A detailed exposure history can narrow the differential quickly and save time. Now, a little bit about the causes of fever of unknown origin or FUO. The causes of FUO fall into four major categories. Number one, infectious causes remain the most common worldwide, such as tuberculosis, endocarditis, abscesses, viral or fungal infections. Number two, non-infectious inflammatory diseases. These include conditions like systemic lupus erythematosus, vasculitis, adult onset Still's disease, and rheumatoid arthritis. Number three, malignancies, particularly lymphomas, leukemias, and metastatic cancers, account for many adult cases. And finally, miscellaneous causes include drug-induced fever, factitious fever, and rare endocrine or granulomatous disorders like sarcoidosis. Now, despite advances, up to 20 to 30% of FUO, and according to some estimates up to 50%, remain undiagnosed even after extensive evaluation. Understanding these etiology groups helps clinicians direct their investigations rationally and avoid unnecessary tests, ensuring both diagnostic efficiency and patient safety. Now, a little bit about initial evaluation and general principles. The cornerstone of FUO evaluation is methodical stepwise assessment. Random testing rarely helps. Instead, structured evaluation based on clinical suspicion ensures that no obvious clue is missed while avoiding unnecessary costs. Most patients with classic FUO who are clinically stable can undergo evaluation as outpatients. This avoids unnecessary hospitalization, reduces cost, and allows gradual testing over time, which can be useful as new symptoms evolve. On the other hand, patients who are toxic, unstable, or suspected of having life-threatening conditions should be hospitalized. This allows rapid diagnostic testing, empiric treatment when indicated, and close monitoring. The most important step in evaluation is history taking. When evaluating fever of unknown origin, likewise, history taking is our most powerful diagnostic tool. Start with onset, duration, and whether the fever is continuous, intermittent, or relapsing. Classic examples are tertian or quartan malaria, or pale abstain fever in Hodgkin's lymphoma. Even if patterns are often non-specific, documenting them helps compare against known syndromes. Always ask about associated symptoms like night sweats, rashes, weight loss, joint pain, or neurological features. The order of appearance can be critical. For example, fever followed by jaundice suggests viral hepatitis, whereas jaundice first and fever later might imply cholangitis. Also, sequence matters. For example, fever preceding arthritis differs diagnostically from arthritis preceding fever. A chronological timeline helps build a clinical picture, guiding you towards specific categories such as infection, inflammation, or malignancy. Next is past medical history. This is invaluable. Past medical history is invaluable. Patients with prosthetic valves are at higher risk for endocarditis. Those with past tuberculosis may have reactivation, and those with cancer should have relapse or metastasis. These histories narrow the search considerably. Also, ask about genetic or familial diseases, because family history can hint at hereditary or familial predispositions. For instance, familial Mediterranean fever, lupus, or rheumatoid arthritis may run in families. Such patients, such patterns prompt early autoimmune testing, which could shorten the diagnostic journey. Also, ask about immunocompromised conditions or states, because a background of diabetes, HIV, organ transplantation, or long-term steroids changes everything. These patients require a wider net, including opportunistic infections and unusual presentations, which can otherwise be missed if we assume they are immunocompetent. Don't forget about social and exposure history. Contacts, residence, and travel. Always ask about close contacts where the patient has lived or traveled. Tuberculosis, Epstein-Barr virus can spread within households, while residence in endemic areas raises the likelihood of malaria, histoplasmosis, or brucellosis. Even time in prisons or refugee camps can signal exposure to unique pathogens. Next is occupation, hobbies, and outdoor activities. Work and leisure often reveal hidden risks. Butchers or abattoir workers risk Q fever. Lab technicians risk unusual microbial exposures, and spelunkers risk histoplasmosis. Even something as simple as gardening could link to soil transmitted infections. Animal, insect, or food exposures. Pets, livestock, or wild animals may transmit brucellosis, cat scratch disease, or tularemia. Insect bites suggest malaria or Lyme disease. Dietary history like unpasteurized dairy can reveal brucellosis or tuberculosis, bovine tuberculosis, and contaminated water raises suspicion for typhoid or leptospirosis. Each exposure adds to the diagnostic puzzle. Now, medication and lifestyle history. Prescription and non-prescription drugs. Drug fever is a frequent masquerader. Ask about prescription and over-the-counter medications, supplements, or alternative remedies. Even common drugs like antibiotics, anticonvulsants, or biologics can cause prolonged fevers that mimic systemic illness. Herbal, recreational, or illicit use. Herbal products and recreational substances are not benign. Cannabis, stimulants, or IV drug use can introduce hidden infections or systemic reactions. Always ask patients to physically bring their medications for verification, as self-reports are often incomplete. And certainly, smoking, alcohol, and sexual history. Lifestyle matters. Smoking increases malignancy risk, alcohol predisposes to liver disease, sexual history can suggest HIV, syphilis, or disseminated gonorrhea. Without these details, clinicians risk overlooking important diagnostic leads in FUO. After history taking, the second but most important part of evaluation of FUO is physical examination. A thorough head-to-toe examination is critical. Many FUO causes reveal subtle signs on detailed exam which can easily be overlooked if the assessment is superficial. Think of it as a detective work. The clues may be hidden. For example, palpating lymph nodes may reveal lymphoma, tuberculosis, or cat scratch disease. Hepatosplenomegaly can suggest infections like malaria, leishmaniasis, Epstein-Barr virus, or hematologic malignancies. Skin rashes or nodules often point toward autoimmune or vasculitic processes. So don't neglect even the details like oral ulcers, conjunctival hemorrhages, or temporal artery tenderness. These small findings can often provide the first lead toward conditions like HIV, endocarditis, or giant cell arteritis. A careful examination is often more valuable than the next expensive test. So after proper history taking and detailed physical examination, the next vital part of evaluation is laboratory investigation. Initial testing starts with basics like a complete blood count to look for leukocytosis, anemia, or cytopenias. A metabolic panel for electrolyte imbalances and renal involvement. Liver function tests for hepatitis or infiltrative disease. These simple tests often uncover critical abnormalities that point toward either infection, autoimmune disease, or malignancy. Next is ESR, CRP, and ferritin. Inflammatory markers provide indirect but helpful information. Erythrocyte sedimentation rate and C-reactive protein are sensitive indicators of systemic inflammation, although non-specific. Ferritin can act both as an acute phase reactant and as a clue to conditions like adult onset Still's disease or rare hemophagocytic syndromes. Elevated values guide the clinician to expand the evaluation into immune and inflammatory pathways. And then comes blood and urine cultures. These two remain indispensable. Repeated blood cultures can reveal endocarditis, while urine cultures may diagnose occult urinary tract infections. And HIV testing should be standard, as HIV can mimic FeO in both its acute and advanced stages. In endemic settings, malaria smears should also be performed early in the workup. And don't forget about leishmaniasis. Next is imaging. So cross-sectional imaging is often essential. Simple plain X-ray or X-ray abdomen can sometimes be rewarding. However, CT scans of the chest, abdomen, or pelvis can detect abscesses, hidden infections, or malignancies not apparent on physical examination or plain X-ray. These scans also provide targets for biopsy when abnormal findings are present. In patients with cardiac murmurs, prosthetic valves, or bacteremia, echocardiography is crucial. Endocarditis remains a key cause of FeO, and echocardiographic evidence of vegetations can clinch the diagnosis when cultures alone are not sufficient. In persistent cases, positron emission tomography or PET and CT has emerged as powerful tool. It highlights metabolically active lesions, identifying hidden malignancies, vasculitis, or occult infections. A positive scan often directs clinicians toward specific sites for biopsy, while a negative scan can help to reassure about benign outcomes. Now, about the role of biopsy. Biopsy often provides definitive answers. For example, temporal artery biopsy confirms giant cell arteritis. Lymph node or liver biopsies can reveal lymphoma, tuberculosis, sarcoidosis, or fungal infections. Skin biopsy, though less invasive, can also diagnose vasculitis or even hidden lymphoma. When blood tests show anemia, pancytopenia, or abnormal cells, bone marrow biopsy is essential. It can reveal hematologic malignancies, mycobacterial infections, or brucellosis. In FeO, marrow biopsy often yields some of the highest diagnostic returns. Ultimately, biopsy provides tissue for histology, culture, and spatial stains. It is often the turning point in FUO evaluation, shifting the investigation from a speculation to confirmation. Without biopsy, many cases would remain unresolved. Now, I will talk about fever diary and monitoring. A fever diary is surprisingly useful. Patients record daily temperatures, fever duration, and heart rates during febrile episodes. This can reveal patterns like relative bradycardia, where fever is not matched by expected tachycardia, suggesting causes like typhoid or brucellosis. Encouraging patients to record associated symptoms such as sweats, rigor, or rashes during fever episodes creates a timeline of events. For example, a rash appearing during fevers that fades afterward might point toward Still's disease. The diary consolidates otherwise scattered information. Small observations, when consistently recorded, may emerge as powerful diagnostic clues. It also improves communication between patient and physician during follow-up visits. Now, something more about advanced diagnostic. PET and CT scan we have already discussed earlier, but to put more stress on its use as an advanced diagnostic, we are discussing it further. PET and CT scanning has become a game changer in FUO evaluation. By detecting areas of increased metabolic activity, it helps localize hidden malignancies, vasculitic processes, or deep-seated infections. Importantly, using PET CT earlier in the diagnostic process improves yield and reduces unnecessary tests. A positive PET CT often directs us to biopsy the right tissue, shortening time to diagnosis. So it is really very helpful. And then comes newer molecular tests. Advances in molecular diagnostics now allow us to identify pathogens that traditional cultures miss. Sequencing and PCR-based tests can detect tuberculosis, fungi, or rare organisms in a matter of hours. These technologies are particularly useful in immunocompromised patients, where culture-negative infections are common. While not widely available everywhere, they represent the future of FUO diagnostics. Perhaps the greatest value of molecular testing is in culture-negative FUO cases. Patients with unexplained fevers after weeks of evaluation often benefit from broad molecular panels that test for hundreds of pathogens simultaneously. These technologies are still evolving, but already offer breakthroughs in some of the most difficult FUO cases. So, after discussing history taking, physical examination, and some about investigations, we should talk a little bit about initial management. Now, in initial management, we have to take some of the precautions. Number one, drug-induced fever is common yet but often overlooked. So stopping non-essential or new medications is an important first step. If fever resolves within days of discontinuation, it strongly supports a drug fever diagnosis and avoids unnecessary investigations. And second point is antipyretics like paracetamols or NSAIDs can mask fever patterns. Unless fever causes discomfort or complications, it is better to avoid them during the diagnostic phase, since they eliminate potentially diagnostic features of fever curves. And finally, about antibiotics. Empiric antibiotics should not be given unless the patient is unstable or suspected to have a life-threatening infection. They can sterilize cultures, delay diagnosis, and complicate evaluation. FUO management requires restraint as much as intervention. Now, a little bit about treatment of FUO. So the treatment of FUO can be divided into three key components. First, general treatment. This includes supportive care, adequate hydration, maintenance of nutrition, adequate rest, and proper monitoring of vital signs. Antibiotics should be used judiciously for comfort, but should not mask fever patterns. Second, specific treatment. So, specific therapy depends on the underlying cause once identified. For example, targeted antibiotics for infections, corticosteroids for autoimmune diseases or inflammatory disorders, or chemotherapy for malignancy. And third, treatment of complications. Prolonged fever may cause dehydration, electrolyte imbalance, weight loss, or organ dysfunction. This must be actively managed. Multidisciplinary input, patient reassurance, and cautious follow-up are essential. Above all, treatment must balance intervention with diagnostic clarity, avoid unnecessary empiric therapy until a definitive cause emerges. In this discussion, we are not detailing all aspects of specific management and management of complications. So now we shall discuss more about outcomes of FUO. As indicated earlier, that 20 to 30%, and according to some estimates, 50% of FUO remain undiagnosed. And one of the most striking facts is that even after exhaustive evaluation, up to half of the patients remain without a definitive diagnosis. This can be frustrating for both clinicians and patients, but this underscores the complexity of FUO and the limitations of our current tools. The reassuring point is that most undiagnosed FUO patients eventually improve spontaneously. Many become afebrile within weeks or months without developing further complications. This highlights that not all undiagnosed FUO equates to poor outcomes. When the underlying cause is found, prognosis varies. Infections generally have intermediate outcomes. Malignancies definitely have the worst prognosis. And autoimmune or inflammatory conditions usually respond well to treatment. Thus, the challenge is identifying those few serious cases early while safely observing the rest. Now, prognosis by etiology. Definitely, malignancy remains the most concerning etiology in FUO, carrying a mortality of nearly 50%. Delayed diagnosis in lymphoma, solid cancers, or metastatic cancers often leads to poor outcomes. That is why maintaining high suspicion for malignancy is so critical. Infectious causes of FUO, such as endocarditis or tuberculosis, have intermediate mortality rates, about 27%. Early recognition and targeted treatment make a big difference. This reinforces why cultures, imaging, and repeated evaluations are essential. Non-infectious inflammatory conditions such as vasculitis or Still's disease tend to have much better prognosis if recognized and treated promptly. Mortality is around 5 to 7%, which is relatively low compared to infection or malignancy. So, summary of approach. Throughout this presentation, one theme should stand out. History and physical examination are more valuable than any single test. They guide the entire evaluation, pointing us toward targeted, meaningful investigations rather than scattershot testing. Every patient should undergo a standard baseline panel of laboratory investigations and imaging. From there, diagnostics should be tailored to findings in the history and examination. This balances thoroughness with efficiency, minimizing wasted resources and unnecessary patient anxiety. Empiric therapy, whether antibiotics or steroids, should be reserved for situations where delaying treatment would risk patient safety, such as suspected giant cell arteritis or sepsis. Otherwise, it is safer to wait, as empiric therapy can obscure the underlying diagnosis. So, in this final slide, key takeaways are: FEO is best approached with structure and patience. Each case must be seen as a puzzle, solved through systematic evaluation while listening to the patient's story and respecting their concerns. And resist the temptation to throw empiric antibiotics or steroids at every FEO case. These can delay accurate diagnosis, create resistant organisms, or mask important clinical clues. Restraint is often the most powerful tool. And finally, remember that many FEO cases resolve without a diagnosis and with excellent outcomes. As long as dangerous conditions are excluded and patients are monitored closely, reassurance and watchful waiting can be the safest and most effective strategy. Thank you all for your patient hearing. Thank you.